Okay, good morning. So one of the questions was, what about the anesthesia? And anesthesia is something that many people have some anxiety about, going to sleep and waking up. And while it does have some risk, in fact, anesthesia in general is a pretty safe procedure. Now, one of the things we found is that there's a lot of new choices and new research in the type of anesthesia that's available so that we can improve the quality of the anesthesia. Okay. Already, even up until last year when we began to change our anesthetic technique, we had a very safe anesthetic technique. It was new, it was different, it used different techniques than most other anesthesiologists do when they do general surgery. So let me talk about that. Most of the time in the United States, Canada, and around the world, if you have major abdominal surgery, you get a gas-type anesthesia. You breathe in an anesthetic gas, and you may have heard of some of the names of these anesthetic gases called halothane and enflurane and desflurane, things like that. And these are all kind of should remind you of the name propane, which is a gas, which we don't use, but not for anesthesia. And the idea there is that these gases are all similar to propane in their chemical structure, and when your body breathes them in, they are kind of a oil, fatty, not water-soluble chemical. They go into the bloodstream and then diffuse into the brain, and the brain does something funny. It goes to sleep without hurting it. So these anesthetics are from the very first anesthetic that was invented back in the 1870s, which was ether, which was also a gas. And those of us who are old enough may remember we had our tonsils out, and we would lay back, and the anesthesiologist would start saying, counting back from 100, and you'd go 99, and then you wake up going, where's my ice cream? So it turns out that anesthetic gases have a long and very positive history as tools to let us do surgery. The anesthetic gases, though, have two big problems that we don't like. One is just unpleasant, and the other is dangerous. The anesthetic gases, as I said, are kind of fatty type chemicals. They're lipid, soluble, oils as opposed to water. So that when you breathe them in, they go into the fatty tissue. And one of the most dangerous complications of the anesthetic gases is in a heavy person in particular, the gas can dissolve in your fatty tissue. You can turn off the gas and wake the patient up, and there can be enough gas stored in the fat so it can leak back into the bloodstream and put you back to sleep unexpectedly. So that you might say, have your surgery, go to the recovery room, be in the recovery room, having everybody saying, oh, you're fine, and then gets partially sedated and decrease your breathing as the gas leaks back into your bloodstream. If that happens in a heavy person after major surgery who already may have lung disease, like sleep apnea or something like that, then we may face the problem they could have low oxygen, irregular heartbeat, or even occasionally death can happen from this complication. So the gas anesthetics are wonderful. Like everything, though, they have a couple of risks. The other big risk, not as dangerous, is that gas anesthetics, for reasons that are not quite clear, cause about a third of people who get them to have severe nausea and vomiting. So if you've ever had a gas anesthetic and you've woken up, you just have this terrible feeling of retching and sick and things like that, and that's no fun right after the surgery. So because of those two problems, we switched many years ago, almost 10 years ago now, to another kind of anesthetic which you get intravenously. And the foundational anesthetic chemical that we use is something called propofol. And propofol is a white, milky-looking stuff. And it is nice because it gives you good anesthesia. It doesn't dissolve in the fat and cause that tricky recovery problem. And instead of causing nausea, it actually is an anti-nausea agent. So that's good. Now that's what we've been using for many years, and most hospitals and most doctors still do not use it because the propofol is much more expensive than the gas. But we felt like you're worth it. Now there's another area of research that has been going on for several years now, which we've taken advantage of starting last June. And this area of research is something that's got a big scientific name called opioid-sparing anesthesia. Opioids are another word for narcotics. So the idea, if you think about it, is when you wake up, if some character has kind of cut on you and sewn on you, or imagine, for example, if you had a total hip. They take a saw and cut off the top of your hip and hammer a steel rod down there with a ball on that, and like, that's pain. It's okay. All right. So we don't want our patients to have pain, and the foundational treatment to protect our patients from pain has been narcotics, opioids, which is good. But like the gas anesthetics we just talked about, opioids or narcotics have their own side effects. One of the big side effects of narcotics is that they depress your breathing. Okay? Now, in a heavy person, when you lay back, that weight lays upon the lungs. You may come to us with sleep apnea or problems breathing, and those things together with surgery where it hurts, and then add in some narcotics on top of that, and people after major surgery can have problems. So on the one hand, you want to have them breathe well. You don't want them to hurt. You then give narcotics, which can then interfere with their breathing, and now you're in trouble. That same kind of trouble that we were talking about kind of with the gas anesthetics, where the respiratory depression of the medicine you want to give hurts us because it's a side effect. So there's a whole area of research where they've looked at stuff, other medicines and other chemicals that we could give to our patients to decrease their pain, but not cause the side effects of narcotics. And so, opioid-sparing anesthesia. Now, I'm going to use a couple of big terms, but basically there are two areas in the brain that have been found that are not opioid receptors, but are different flavor receptors, where if we give a drug that stimulates them, you have less pain. We like this. One receptor is called the NMDA, which is the N-methyl-D-aspartate receptor. You can just remember that as one. And then the other one is an alpha-2 central receptor. And drugs that affect the NMDA or the alpha-2 receptors take away your pain. Sound good? So what we thought is we looked at the research, and there's some research on some good medicines. One is a brand new medicine, and one is an old-timer medicine. And one works on the NMDA receptor, and one works on the alpha-2 receptor. And we've added that to our anesthesia. And what we found is we've decreased the pain, we've decreased your need for post-op narcotic pain medicine, and thereby making it safer. Now the two medicines, one is an old-timey medicine that we've had around forever. It's called ketamine. And they actually use it as a tranquilizer in a lot of different animals for animal anesthesia, and they use it in kids and burn patients. But it had a side effect of sometimes causing nightmares. And so we found if we give another medicine, Versed and dexmedetomidine, two other medicines, we can decrease that side effect. But ketamine works on one of the receptors in the brain, it decreases your pain. Another side effect of ketamine is it's an antidepressant, so it makes you happy. So they looked at people who come into the ER, maybe they've tried to commit suicide, and they're depressed. So what can you do? Well, you could give them a prescription for Prozac, right? But the problem is Prozac takes 2 weeks to work. So they were interested in finding a drug that would cause antidepression within minutes. So they got a group of patients who were depressed. They filled out a form asking them questions. They said, I feel sad and don't feel like living, and Then they started a drip of the medicine ketamine. And within 20 minutes, their depression had lifted. And it lasts for a week. So you're welcome. Part of the opioid-sparing anesthetic technique will include a dose of the ketamine with your surgery today, and that dose will decrease your pain. It actually, instead of depressing breathing, stimulates breathing. Instead of dropping your blood pressure, it stimulates the blood pressure a little bit, so it improves the safety. Then the second drug we use, which is dexmedetomidine, or Precedex, is another drug. It works on a different receptor in the brain, and that receptor also has been shown to decrease your pain while protecting your airway, making you breathe better, and it helps decrease the side effects of the ketamine. Now, all this is a lot of noise and fairly complicated, but we can go back to yesterday's clinic. Do you remember we had like 3 or 4 people from surgery last week, right? Did anyone say anything about the anesthesia? Right. And that's what you want. In other words, in the end, all this is fairly complicated, and we were going to talk about it, but the bottom line is we want you to be just like our patients we met last week who said nothing about the anesthesia. We expect for your experience today to be nothing but good. Kind of like an airline flight where nothing happens. That's great. No excitement, no danger, minimizing the risks, and that's what we've done in our best new additions to our anesthetic technique. We're extremely proud of it. It's extremely safe. We have very minimal side effects, and so all in all together we think it's a great choice for you, and I think you'll like it. Other questions about anesthesia?
After the week of feeling happy, do you crash?
No, you're then like wherever you are now. And so it's not a, well, yeah, in other words, it's not a long-term treatment. You can't say, well, let's give people ketamine. It doesn't work. It works for short, it works quickly and works short-term. And then you have to look into the issues for depression that everybody struggles with all the time. It's not like a magic treatment, unfortunately. It's great if you have to do something for a period of time, especially if somebody's terribly depressed. In our case, it's just a kind of a nice little perk of the anesthetic technique that we use. And we've certainly seen that where we've had a few people who seem to be just a little bit less grumpy or a little bit less, kind of sad or irritated. So we think it's a real advantage.